Now let's talk about nephrology in the next part. Let's examine the urine casts. Urine casts, some horsefall proteins are secreted by the thick ascending loop and make a high-laying cast. It is a normal finding. Muddy brown granular casts are characteristic of acute tubular necrosis. Red blood cell casts, dysmorphic red blood cells, characteristic of glomerulonephritis. White blood cells, granular casts, are characteristic of interstitial nephritis or acute pyelonephritis. Oval or round fat droplets in polarized light have Maltese cross appearance, proteinuria. Waxy cast or broad cast, characteristic of chronic kidney disease. Now let's examine acute renal failure. Acute renal failure could be pre-renal, intrarenal, or post-renal or obstructive uropathy. Post-renal, let's examine the last one first. In the elderly, it is mostly secondary to prostate enlargement in male, pelvic tumor, cancer of the cervix in female. Young adults, the main common cause are stones. In children, urethral valve, urethral stenosis, stenosis of vesico-ureteral junction. Post-void residual more than 200 ml, highly suspicious. Test of choice is renal ultrasound, which we have dilated bladder, ureter, calyceal system, hydronephrosis. Ultrasound negative, no obstruction. Ultrasound positive, look for the cause. If there is no obvious cause, do intravenous pyelography or retrograde pyelography. Treatment in the lower tract obstruction is Foley's catheter. In the upper tract obstruction is ureteral stent or percutaneous nephrostomy. Once obstruction is relieved, massive diuresis can occur. Treatment is intravenous fluid, 75 centiliters per hour. Now let's examine the ratio between BUN, azotemia, and the creatinine. If it's more than 20:1, the cause is usually pre-renal. If it's less than 20:1, it's renal. Urine sodium, if it's less than 10, usually it's pre-renal. If it's more than 20, it's usually renal. Fractional excretion of sodium, if it's less than 1, is pre-renal. If it's more than 1, is renal. Pre-renal, secondary to poor renal perfusion. Causes are mainly dehydration, peripheral vasodilatation like in sepsis, low cardiac output, congestive heart failure, GI bleeding, excessive diuresis. Treatment is intravenous fluid. Now let's examine the last one, the last cause, that is intrarenal. Acute tubular necrosis, we notice muddy brown casts, fractional excretion of sodium more than 1%, urine sodium more than 20. Causes are mainly ischemia, dehydration, GI bleed. Usually patients are oliguric, or toxins like aminoglycosides, radiocontrast, or myoglobinuria secondary to rhabdomyolysis.